So I think that was 2 minutes and 59 seconds, so you did good. All right, I'd like to go ahead and welcome up our first panel this morning, please, if I could have you come on up. Our first panel this morning is the intersection of student insurance and access to care. Our moderator today is going to be Diane Dawson, who's the Comprehensive Care Manager and Nurse Manager for Carnegie Mellon University. Please join me in welcoming our first panel this morning.
Bear with us as we wait for one more panelist here.
He's worth waiting for, really.
Good morning, everybody, and welcome to the first panel discussion today regarding intersection of student health insurance and access to care. My name is Diane Dawson. I'm the Comprehensive Care Manager at Carnegie and Nurse Manager at Carnegie Mellon University, and I'm also the President of the Mid-Atlantic College Health Association. This morning, I'm joined by Dr. Michael Huey at the end down there, the recently retired and happy, I think, Vice President and Executive Director of the Student Health Services at Emory University and immediate past President for ACHA. Susan Pearson in the middle is the Senior Director of Client Services at Aetna Student Health Insurance, and Dr. Ralph Manchester to my right, Vice Provost and Director of the University Health Services at the University of Rochester and past President of the American College Health Association. Thank you all for joining us this morning.
Thank you.
It goes without saying that health insurance has been a leading new item and policy topic for several years, and there's been a flurry of regulation and legislative changes to health insurance and the Affordable Care Act. It started a debate about a subset of insurance that we're all familiar with and deal with day to day, but the general public might not know much about it, and that is the student health insurance plans. For our purposes this morning, this panel is convened to discuss the intersection of these plans with student health and wellness, what has happened and where it does seem to be going with these plans, and the impact of the recent regulatory changes in this arena. The goal of this panel is to have the most robust discussion on this topic, so please do not feel limited to a question and answer format. So first off, what is a student health insurance plan, and what role do these plans play in student health? Anybody?
Well, unfortunately, that's a question that we get asked all the time by legislators and people in regulatory positions in government. Oh, if there are student health insurance plans, what are those? And so it's sometimes an uphill battle for us when we're doing advocacy. When I first came on the board of directors of ACHA 4.5 years ago, I don't think that I could have imagined that we would have gone through the changes to the national health insurance landscape that we've gone through in the past 2 years. It seemed like ACA was really hitting its stride. And the American College Health Association, Jim Turner was our president during that one very crucial year where a lot of the regulations were being put in place. And we did a very good job of making sure that students were included. And then there was ironing out of details over time. But with the regulatory changes that have happened under the current administration, we've had to scramble some to try to figure out how to maintain the best quality student health insurance plans that we could for all of us who are providing the care and for the students and dependents for whom we're providing that care. We're lucky at ACHA that we have a lot of foundational documents, and so when I read the first question, what is a student health insurance plan, I thought, well, maybe I should just go to the document that's called Student Health Insurance Plans. This was written by the Student Health Insurance Plan and Benefits Coalition a number of years ago, and there was a recent update in November of 2017 of what should we have in our insurance plans. And I'm not going to read you all 11 actually, of the items in that document, but there are some things that the coalition felt were vital to being able to provide a quality student insurance program on our campuses, including requiring proof of insurance from our students. And that's a battle on most of our campuses. Many of us now do have waivers or hard waivers. There are even some campuses where all students purchase or have purchased for them the student insurance plan. But that is one of the foundational recommendations is students should be insured. It's difficult to make it through your 4 to 8+ years at a university and not have that comfort of being able to get the care you need before your problems become serious. Some of the other guidelines are that it should be a primary plan and not a secondary plan, that it be managed in the best interests of the students on our campus, that it be reviewed annually, that there be input from our consumers, from our students on the formation and updates to the plan, but also that there be involvement of those of us who are providing that care across the spectrum of care, as well as other internal and external experts to help us create a plan that works best in our individual situation on our campuses, and that it meets the needs of our students for benefits at the lowest achievable rates, and that there be full disclosure about who benefits from any residuals on the plan at the end of any given year, that it be a competitive process, that there not be conflicts of interest, and that the plan not discriminate against students in any of the categories on our campus, and the needs of our students based upon their identities and their backgrounds and their levels of resources are so variable that we want to be sure that we're aiming for a plan that gives coverage to all students. So I took the easy answer, which was just to tell you about the document. And if you haven't looked at it, it's really not very long. It's about a page and a third. And it's well worth reading through, because you'll find some things in there and go, we might have lost our way on that a little bit, like what happens when a student has to drop out for medical purposes. And one of the recommendations is the plan stays in force. And that is a difficult one for many of our campuses. But that's what our experts in college health feel is the structure that we should have.
Well, I would just add that as our students and their families think about this, there's always a degree of confusion about what is covered by the student health insurance plan versus what is covered by whatever funding mechanism is in place on the campus for that institution. And it gets argued both ways. Sometimes we hear, well, I've got insurance, why should I have to pay the mandatory health fee? And at the University of Rochester, the simple answer is, what was that first word you said? Mandatory? Right. And then it's turned around the other way and said, well, I pay this mandatory health fee, why do I have to have health insurance? But student health insurance plans are typically if they're well designed, better coverage and lower cost than students can get through other sources, at least if they're looking for their own insurance. And a large reason we can do this is because we do provide on many campuses the primary care right where the student is, in a way that is accessible and custom-made for that population. So the two things work well together.
From the insurance carrier perspective, I would agree, certainly with both of you. I think the one other thing I would add is really for us, it's having clear communication, with all constituents on campus when possible. Certainly in getting student engagement. And our plan designs are really centered around the health centers most often. So it's designing those benefits to have one big package and clear understanding of the student's care overall.
Thank you. Briefly, where have these plans come from over the past few years, and where do they appear to be going? And what trends have we seen in student health insurance?
You want to start, Ralph?
Sure. I think all of us are aware that before the Affordable Care Act was passed, there was we'll kindly say, a wide variety of student health insurance plans available for college students to purchase. And some of them provided very little coverage when students had anything more than a fairly minor problem. And the Affordable Care Act set a minimum standard for anything that's going to meet the requirements to have health insurance when we had an individual mandate. That on the one hand, raised the cost in some, depending on how you look at it, because those low-cost, low-coverage plans were not an option anymore. But they provided some basic level of coverage, and we'll talk about the essential benefits, I think, a little later. So I think most of us on the college health professional side saw that as a major step forward. It probably wasn't perfect, but at least we knew that even students who were on a bronze level plan had coverage for healthcare costs, and it greatly decreased the probability that they would encounter a healthcare problem that would be so expensive that they would not be able to continue their education. The healthcare problem itself might be so serious that they had to at least temporarily suspend their education, but that did a good job of protecting students against that financial risk.
The removal of caps through the Affordable Care Act and the removal of pre-existing condition exclusions, I think, were the two biggest things that had an impact on our campus, because we always felt that our insurance plan was pretty good as student insurance plans go, and we actually had eliminated pre-existing conditions many years before, but we struggled and struggled with caps on the pharmacy plan particularly, and then for our students with the most serious illnesses, having a total cap of, say, $250,000, which it's very rare. We only have a few students that go through that in any given year, but when they go through it, sometimes they really went through it. And that was a career ender for students. So recovering from that level of debt, in addition to recovering from that serious of an illness or injury, was a permanent derailer. And so that, I think, was what we saw over the previous few years, seeing the elimination, essentially, of the short-term, low-coverage, quote-unquote, junk plans, and plans that had to meet the insurance mandate to be offered, made a big change.
I think you're hearing a lot of students now saying, they're a lot happier with the plan benefits that they have, right? So we feel like we're really giving them something for it. Of course, it's not 100% coverage for everybody, which they still want to see. But I think you're right that that's the biggest change, that they really have become very valued insurance plans. We are seeing other trends come out of that. Now we're having to look at the data more closely because we're seeing, pharmacy skyrocket, a lot of specialty medications coming into play. So there's a lot of other things to look at, but really they're better value for the premium.
I have a lot of parents tell me they wish they could purchase the student health insurance plans for themselves and their families. Anyways, next question is, what role did the Affordable Care Act play in the development of student health insurance plans? Some of that was covered, but a little bit more detail.
Yeah, there are some other things that were part of ACA that I think were very helpful. And actually, this one that I'm going to mention maybe should have mentioned when I was talking about the big changes. But mental health parity, I think, was a major step forward for most of us on our campuses. And many campuses have gone to mental health superiority, where they'll have no copays on mental health or no annual deductibles on mental health. And none of us can put together, with rare exception, a mental health program on our campus in terms of behavioral health, psychiatry, substance abuse coverage, relationship and sexual violence coverage that meet every single need of every student. And yet, I think that you see again and again in our communities that the number of providers in mental health that accept insurance at all is significantly lower than you find on the medical side, and that when a psychiatrist or psychologist isn't accepting insurance, that the costs can be astronomically high for our students. In Metro Atlanta, a new psychiatry visit is $400. And so trying to convince a student that we don't have room in our psychiatry unit and we want you to go off campus, number one, find somebody. Number two, it costs you this much money. The ability to improve our level of mental health coverage under ACA because of the requirements, I think was really very important to us. Coverage of students under their parents' plan until age 26, and as we know, that's one of the things that's made it through and has escaped regulation because I'm sure that it's essentially 100% popular across the nation. And so, but that was a big step forward for many of our students. And I think that the medal ratings that Ralph alluded to earlier, the ability to say our plan is a platinum plan, or it's a gold plan, or it's a bronze plan, and have people, as they got increasingly sophisticated about insurance under ACA, our students and their families and parents could understand what that meant and what level of coverage they were able to get, and maybe be able to compare that to the level of coverage that they could get from a plan on one of the insurance exchanges or on a family plan that they currently had through an employer, and that it gave tangible evidence of the value of our student insurance plans. So not only did it help students in terms of making decisions, but it was a marketing tool, really, to be able to say, look, we've been telling you for years that our student plan is really excellent, but here it is. It's rated at 94%. It's a platinum plan or it's a gold plan. Was really, I think, valuable in terms of them understanding what sort of availability they had on campus.
Yeah, and Mike mentioned earlier the role that ACHA played as the Affordable Care Act was making its way through Congress, and I just want to underline that, as many of you know, the Affordable Care Act recognized individual coverage and group coverage, but group coverage was defined as employer-sponsored plans. So college student health insurance was neither of those. It wasn't individual coverage because we were defining a group, but the group didn't fall under the employer-sponsored health care definition that was originally part of the Affordable Care Act. And it was through the work of a number of people in ACHA and some other groups as well that we got a definition for college student health insurance that has allowed us to offer the plans we offer today.
Go ahead, Susan.
Yeah, I'd just say, I think the other addition has really been 100% coverage for preventive care. That's been really big. And I think you mentioned the dependent age 26, so.
And Ralph had already talked about the individual mandate and that ability to spread risk, something that hasn't been as big a problem in student plans because generally speaking, our populations are of lower risk than gender and age matched populations outside of college and university settings. But the individual mandate to spread the risk on plans that were available on the insurance exchanges, the ACA, state and national insurance exchanges, I think made a big step forward as well.
Right, and the individual mandate on a national level is really the equivalent of an insurance requirement on your campus. And we've all heard about campuses where they have no insurance requirement, but they sponsor their own plan. And as premiums go up, students who think they're not going to need health care services drop off the plan, leaving the students who know they will need health care services, which makes the premium go up, which makes more students drop off the next year, and it's the death spiral.
Cost is definitely the factor. So what impacts have we seen from some of the regulatory changes that have come down over the past year, like the repeal of the individual mandate or the expansion of short-term limited discretion or duration plans?
Big, and it's something that we're talking about on our campuses and certainly nationally at ACHA and working with our sister organizations across higher education to try to get messages to the people making these regulatory decisions that as you chip away at the regulatory integrity of ACA, it makes it very difficult for us to maintain requirements on our campuses for certain levels of care. I think it helped a lot of campuses when ACA went live and there were exchanges, knowing that students could have access to insurance plans that maybe were not the insurance plan that you were offering, but had a solid baseline of coverage. And so now we can say, if we're putting in a waiver system for our plan, we don't have to feel like we're really forcing students to take a plan. And many of us built our plans to be exceptional in terms of coverage in our situation. We have an academic medical center, so we could tool it to have multiple tiers of coverage, with the academic medical center being by far the best coverage. And that students didn't necessarily have to say that's the right plan for me, that they could have access under the exchanges to a quality plan that would work for them in our city and our state. So the removal of that individual mandate that led to significant drop-off of insurance companies participating on the exchanges and the number of choices really dwindling in our state. It's astonishing how few choices you have now on the State of Georgia Insurance Exchange. My son's on ACA. He works in the food industry, and there's not a lot of insurance coverages for the people that are serving us food in our restaurants, and he's one of those people. But the price of his insurance essentially has quadrupled and now quintupled, and his options of plans that he could choose has become extraordinarily more restricted. So the loss of the individual mandate and the effect that it had on insurance companies being willing to stay the course and stay on the exchanges, I think, has been really, really huge. There's also become, I think, a significant difference between our states, and we'll talk about Medicaid soon in terms of out-of-state versus in-state Medicaid, but there is a difference in the states that have accepted the expansion of Medicaid with the assistance of the federal government and those who haven't. And I looked it up last night, and there are 33 states and the District of Columbia who have accepted the Medicaid expansion and 18 who have not. My state is one of the ones that has not. And that Medicaid expansion is in those first 3 years, 14, 15, 16, the government was providing 100% of the financing for that expansion, and then it was going to decrease over time to 2020 when it would be at 90%. And so making it an option and a positive option for many of our states, including states that were very much against federal government intervention, but found that by accepting Medicaid expansion that they were able to significantly increase the coverage of the people that had limited means in their state. So, and that still does exist, but that was one of the things that we have talked a lot about because it wasn't something that became part of our ACA in our state, and then as regulations came in and started to remove the individual mandate, it became less important seemingly to legislators to go forward with the Medicaid expansion.
I think there's work being done on the Medicaid expansion and just Medicaid in general. If there's opportunity to work to see if, you can have the students on the schools plans and the premium covered through that. So it'll be interesting to see where that goes in the future. I think with the penalty being removed from the individual mandate, and you're right, there are a lot of carriers, us being one of them, that's pulled out of a lot of the states, what that long-term impact is to our student plans will be interesting to see bear out.
We've spent a lot of time at ACHA and in your states with your organizations looking at ways, because it's a state-by-state issue. Medicaid is a state insurance plan, and so working with your state legislature to have SHIPs be used in lieu of Medicaid, as Susan was talking about, is a huge project for most of us, and most of us don't have a lot of experience in lobbying at the state level. And so one of the things that ACHA and the SHIPS Coalition have been trying to do is to put together supporting documents that can help as you try to get coverage of your student plan under Medicaid. And we've had some successes. It's been limited. And I used to know what the states were. Devin, you can mouth it to me and then I'll. Yeah. Is New York one of them, Ralph?
No.
Okay.
New York has an abundance of regulations for things, and in New York, Medicaid is actually a shared state-county program. So we don't have a New York State Medicaid program. We have, I don't know how many counties there are in New York, 50-something Medicaid plans in New York State. So our students in Rochester, unless they lived in Monroe County before becoming a student, when they got Medicaid, their Medicaid plan is almost worthless. It covers emergency care and basically nothing else. So we have students from Buffalo and Syracuse, which are roughly an hour drive east and west from us. And when they come in to see us, say a woman chooses to get an IUD, sorry, you can't get it done here and have Medicaid pay for it. You'll need to go back to Buffalo or Syracuse or New York City. And that is the kind of thing that having a student health insurance plan in lieu of Medicaid would be a great solution for, because it would provide excellent coverage for the student while they're at school, still provide excellent coverage when they're at home, and it would actually save the state money the way they do the financing of the Medicaid program, but those don't seem to be good enough reasons to get this done so far.
And out-of-state Medicaid, of course, is the big issue for many of us, particularly those campuses where the majority of your students don't come from your state. And so the same problem that Ralph describes in New York across counties is the problem that we have in Medicaid in our other states. And I think the majority of student health services don't bill the Medicaid program, so that's one hurdle to get across. But the second hurdle is your students who are coming from other states that have a good baseline of coverage in their state or home county and have only emergency coverage in your state. And are you going to say that those students, someone who has restricted means and is able to get Medicaid coverage, are you going to tell them that they failed your waiver because their Medicaid doesn't work? And if they do, where do they find the resources to purchase the student plan? Does that mean more loans? Most universities aren't in a situation where they can step forward and pay for the student plan for students on out-of-state Medicaid. So it's a complicated issue on many, many levels that ACA didn't solve. And in the current situation, we haven't solved it either.
Well, and I should say that in New York State, we do have a pilot program at Cornell University, which Val Lyon was leading the charge on creating, where Cornell students can be on their student health insurance plan and have Medicaid pay the premium for it. But just because it's working at Cornell doesn't mean that New York State wants to do it anywhere else.
So what role do essential benefits play in the student health and wellness?
I think we've talked about this already a little, but there's a list of, 10 or 13 specific types of health care that must be covered, and that sets the level playing field, and then these metallic levels that we were talking about say what percentage of the costs of delivering those essential benefits will be covered by the insurance versus what will be covered as an out-of-pocket cost for the individual. What will happen with those in the future? Hard to say, although it's kind of a moot point, because without an individual mandate, nobody has to buy the plan in the first place.
Yeah. And we went through an interesting process under ACA where you could only move 4% in either direction or 2%
plus or minus
in either direction. And so those of us that found ourselves sitting right on the borderline of a difference between a platinum and a gold plan or a gold and a silver plan, were having to make the decision about whether we were going to add additional benefits to move up or cut benefits to move down, and we didn't want to do either of those things really. We felt we'd built the plan that we wanted for that given year, but we had to make that change. And the regulations that have come into play in the last 2 years, I guess if nothing else, removed that requirement that we couldn't sit on the border, that we had to be fully into one metal area or fully into the other.
And our plan was actually super platinum. So when that first went into effect, we had to put in some higher copays, or maybe it was a higher deductible, in order to get the percent coverage down to 94.000%. But now that we're self-funded, we don't have to follow that rule anymore, and we eliminated the deductibles.
So what role does the long-term outlook for these plans look like to you?
Predictions are difficult, especially when they involve the future.
I think that we will see continuing efforts to chip away at the Affordable Care Act changes and enhancements by regulation. And those of us who care so deeply about the health and well-being of our students are going to see those things, and then we're going to try to work through our national organization and with other national organizations to see if we can't take a stand against these regulatory changes. But I don't see in the next 2 years that all of a sudden we're going to have enhancements back to ACA and reversals of some of the decisions that have been made. So I think what the future holds is, at best, where we are, and at worst, potentially additional regulatory changes that we didn't see coming. Some of the most sophisticated of us about student insurance plans probably do see some of these things coming. I'm always surprised when I get the message from ACHA or from other student health colleagues that, do you know what's about to happen? They're going to make another change, and this is the impact that it will have. So we're really grateful to the experts that we have on the ACHA SHIPS Coalition, because their content expertise is astonishing, and it's so helpful. And that leaves those of us who are right now in leadership positions that we can try to master the major concepts so we can send the messages, but we've got a lot of people who are looking very carefully at the details and helping us to figure out if we take that tack that we could gain this but lose this even bigger thing.
Certainly, there's no crystal ball. I think that, one of the things we need to do is keep focusing on the plans that you have in place right now. Communication is key. How do we get the message about what is being offered in these programs and their value to the students, working with the schools on making that message very clear and positive, continuing to maintain the enrollment, and demonstrating the plan's overall value. So,
Policy and advocacy, continuing.
If we continue to see movement towards short-term duration, low coverage plans, that's going to have an impact. It's going to make it that we have to really think through. If we've got a waiver on our campus, we have to really think through how do we structure that in a way that students can't waive with the 3-month plan and then not be covered for 9 months. And does that mean that we have to go through a waiver process for tens of thousands of students 3 times a year? It's a daunting thought. So making sure that we try as best we can to show what could be the potential impact of students returning to these low coverage plans that don't provide them longitudinal coverage, and making sure that we help our students to understand that that isn't going to meet the requirements of what we want you to have on our campus. That makes it incumbent upon us to struggle to keep our rates down. And it's always a struggle to make sure that you try to maintain the quality of your plan in the face of being told, well, our rates have to go up this year 15%, or we're going to cut these things, and we can keep it at 8%. It's been pointed out to me by people on our campus many, many times that if we come out of a negotiation for the plan at 7 or 8%, 7 plus 7 plus 7 plus 7 is 28% over 4 years. It's a lot of increase, and generally that increase is coupled with a decrease in coverage. So it's a big double whammy.
Which leads to my final question of what changes would you recommend to make sure these plans remain stable and provide students with affordable, robust access to care.
Vote. And I think even though things are unlikely to get any better and may get a little worse, as Mike said, on the federal level, we do have some opportunities in some states to work with legislatures to address some of these problems. I know in some states and on some campuses, there are discussions about requiring health insurance puts a financial barrier in the way of getting an education. But I think we need to work with those decision makers to help them understand that it's the illness or injury that gets in the way of the education, and we need a mechanism in place so that whenever that happens, the student remains financially whole, can recover, and continue with their education. But I know that's an uphill battle in some jurisdictions.
Depending on the level of resources that you have on your campus, those of us who are lucky enough to have our own medical centers need to keep in mind that if we have an insurance plan, we're paying us to provide care to our students, and it's really a big carousel of money, and it isn't as simple as, well, if we give every Medicaid student on our campus, let's say that we make the social justice decision on our campus to provide the student insurance plan for students who are on Medicaid across the entire country. Let's say we decide to do that, and here's the cost. We figure out everybody that's on Medicaid on the campus, and it comes out being a 7-figure number. Well, if you're fortunate enough to be providing your own care, then you're paying for insurance to pay yourself to provide the care, and really it's not a 7-figure number. It might be a 6-figure number or a high 5-figure number. So trying to look through the intricacies of how your healthcare system is in place and who pays who for what is something that I suspect that decision makers above us know, but when we make it clear that we know, it can help to move the conversation forward.
I think there's a lot of talk yesterday about data, and it certainly applies here as well. You know, what are the sweet spots? Certainly taking a look at the plan and making recommendations, looking at your network strategies, referral patterns, you know, what services are being offered on campus, make sure members are going to the right providers. All of that is critical to the success of these programs going forward.
Programs are about relationships at their very basis, and so looking at your surrounding community and figuring out who out there, maybe they trained at your health center, maybe they were a postdoc in your student mental health office, and now they're seeing patients in your community. They've established a practice. Time for a one-on-one talk. You know, we gave to you, now we want you to give back. We'd like you to see students. We know that you don't accept insurance, but we'd like you to accept our insurance and accept this level of payment. And it can work to work at that individual level. The other thing that we talked about yesterday was insurance as a social justice tool. And it's a complicated area as you make decisions to cover care for a small but real subset of your student body, where the numbers may be small, but the impact of that care is astronomically positive for that student or set of students. And so you're making a decision, you're weighing, are we going to accept this increased utilization of under our plan in order to provide care for this important, marginalized, often subgroup of our students. And many of us have gone through those things where we're trying to decide, are we going to have a prep clinic on our campus, when we realize that when we open that up and students start coming in, that all of a sudden, in terms of expenditures on individual drugs, that Truvada goes up and up and up the scale. And that certainly was the experience at our clinic at Emory, where Truvada was 20th or 25th. I'm looking at Sue Andrick Turner, our account rep. And then all of a sudden now it's 14, and then now this year it's 3, and now it's 1. And the number of people that are using that drug is relatively small, but you might have 2 people or 3 people on a very expensive disease-modulating drug like Humira, and it's the number 1 drug on your plan. So, you're reaching out to subsets of students. Are you going to cover transgender hormonal therapy? Is that specialty coverage that you don't think should be part of your plan? I can tell you that when you talk to your transgender students, they will say to you, transgender hormonal coverage is primary care to me. Without that, I'm not a person. And so you weigh those things as you're making decisions, and it's in a lot of different areas. It's things like covering for surgery for morbid obesity. Is that something that you do? Do you think that's a role for a student insurance plan? Well, it can be life-changing for a small but very real number of students on your campus, and what is the cost of that? Coverage for fertility services, is that something that you're going to cover? Maybe that's very important to a small but real subset of your students, just like abortion services coverage is important to a small but very real subset of your students in any given year. How do you decide which of those things you're going to bring in? And that's why having your students, your consumers, and your experts, your financial predicting people, and working carefully with your carrier to make those decisions is so important. We have been warned. My university, where I'm still part-time employed, self-insured for the first time this year, and the danger when you do that is that all of a sudden you're making the decisions, and let's buy everything, let's give everything, let's remove every copay and every deductible and cover everything under the sun, and then you crash your plan in 1 or 2 years. And so you have to be careful about what you bring in and think about the impact and try to weigh social justice and equity with the cost to the plan and reach what is the right decision for you and for the students that you're trying to serve.
We have time for one?
Yeah, I think we have 1 or 2. One question came in on was, how are your student health plans addressing DACA students?
At the University of Rochester, in compliance with federal and state law.
DACA students are students, and we had a ACHA public statement on DACA when things were really, really hot and it didn't get delayed. But they're students, and they follow our requirements, and they benefit from the benefits that we give to all of our students. And so DACA students are American students, but we feel the same way about our international students. We want to be sure that they have access to the coverage they need. Does that answer the question?
I think it does.
Yeah, okay.
I have one other question I want to throw out there is what came out online is access to dental care is a big issue for students. Can you talk about how you manage dental insurance?
It's changed over the years for us, and when we were in a particularly difficult negotiating year with not a good loss ratio in the previous year, we made decisions to cut certain things, and one of the things that we cut was dental insurance. And as we had some good years, we realized that we would bring it back. Probably of all the things that we did, it was the most popular decision with our students. They're crazy for dental insurance, and they're crazy for eye coverage. And bringing those things in really gets you a lot of positive glow from the student body. It's not always easy to, dental insurance, in my experience, it's not like a medical insurance plan. They have caps on them, and we'll pay $750 for $1,000 of dental coverage. That's very different from what we experience with our medical coverage, but I think that it's important. It's particularly important to your international students, who many of them have not had access to quality dental care throughout their lives, and they'll come in with some big-time needs in terms of infection and root canals and tooth extractions, and so having access to a dental plan can be very helpful.
Okay, I'd like to thank all our panelists for joining us this morning. I'd like to thank our audience members and our live streaming for joining us throughout the day today. Hopefully, we'll take away some new insights and take a 10-minute break. We'll be back to see the next panel that's focused on student insurance as well, enhancing the student well-being through student health insurance. Thank you.